Hello, everyone. This is Ray Blaylark with Sickle Cell Foundation of Minnesota. We're going to give it about 90 seconds so that everyone can come into the room who's waiting to get in or trying to get in. So give us a moment and we'll be right with you. We're having a little bit of technical difficulties today. So normally you would see our slide that says that we'll be beginning in one moment. But you know what? When we have technical difficulties, the show must go on. So We're going to make it work, and we are so glad that you're here. We will start shortly. Okay, let's go ahead and begin. Like I said, I'm Ray Blaylark. I am the founder and the executive director at Sickle Cell Foundation of Minnesota. You are joining us today for our Living SickleSMART series. It is a virtual education series that we started back when the pandemic began, and we are so glad that we did. It's one of our most popular programs. We love it. We have a broad audience and we can reach people all over the world. Not to mention, at the end, we do record these videos so that we can upload them to our YouTube station and share them with you on demand. So go ahead and share it with your friends and family and anyone else who you think might be interested in this show. I want to make sure that I give a huge shout out and a thank you to our spring and summer sponsors of our SickleSMART series: Beam Therapeutics, Children's Minnesota, Be the Match. And then we are also a part of the CDC's, or Center for Disease Control, Sickle Cell Data Collection Program here in Minnesota. So I have to also give a shout out to the Minnesota Department of Health Newborn Screening and Long-Term Follow-Up Program, whom we work very close with. And so without further ado, I don't have my presentation slides that I typically have. Like I said, that's okay. The show goes on. But I want to introduce to you someone who is so incredible to me. I'm so impressed and so inspired for a ton of reasons. But I want you to meet Dr. Simone Uwan. She's going to be able to tell you about herself much better than I ever could read off of a piece of paper. But know this, she is both a physician and she's a sickle cell thriver. She is living well with sickle cell and she's doing some great things. But one of the great things she's doing is teaching some health education that's important to us all. So I'm going to turn it over to you, Dr. Simone, and you can take it away.
Thank you so much, Ray. I have much love and appreciation for you too. So please let me say that. And thank you so much for inviting me to be SickleSMART. I actually think it's a really incredible thing that you're doing, just to have that education out there. Our community needs it, and to have it on demand is also truly special because then it's available for everybody. Gosh, I don't know where to start as far as myself, but I started in the sickle cell public space. I've always been a sickle cell advocate behind the scenes as a physician. I saw sickle cell patients in my clinic. It was my joy. And then just like life will happen with sickle cell, it did, and caused me to have to stop practicing. So since then, I've been, I kind of used it as a moment to pivot and ask God what that meant for me next. And the direction that came up was to tell my story, which I did in 2018. And you all, the sickle cell community, were very gracious, received it. And since then, I've just been writing to inform both the sickle cell community and the medical community about treating sickle cell disease, and just wanting us to all be sickle cell thrivers, not just survivors. So, so this talk that I'm going to do comes from that, springs from that. I started again in the pandemic because people had decreased access to care and couldn't go into the emergency room with an advocate, and so had to know what they needed and how to self-advocate. And I wanted them to know what they should be advocating for. And then since then, I started a nonprofit organization called Sickle Cell Medical Advocacy. And part of what we do is just this, is just teaching what people need to know to make sure that they get through successfully the emergency room and the hospital and come back out to live their big, incredible lives. So with that said, I think that I can go ahead and start. Ray, is that okay?
Perfect. Go ahead and share your screen.
Awesome. Okay. So let me.
While you're doing that, I just want to remind people that the comments box is open, as well as the Q&A. We invite you to add your questions to the Q&A button at the bottom of your screen throughout the presentation. And once Dr. Simone is done with her presentation, then we will open it up and go through all of the Q&A. So keep asking those questions. We love that part of interacting with our guests.
Awesome. And even though we just did our, as life would have it, let's see, and let's see, I think I found it. Let's see where we are. There we go. Yes, awesome. All right. Things like to shift and just keep us on our toes. I've decided life likes to do that. All right, so I'm going to talk to you today, as you know, about IV fluids in a sickle cell crisis. And I'm trying to put this in slideshow mode so that we can, you can see the screen as well as possible, but it's refusing to go into slideshow mode. So I think I'm just going to continue this way. Is that okay, Ray?
Absolutely. Around here, we just make it work.
Exactly. That's what I thought. All right. So, so we're going to talk about the correct IV fluids in a sickle cell disease crisis. I remember having this conversation with, oh, ouch, I was supposed to remove that webinar that comes from the class, so ignore that. So I had this conversation with Dr. Iffy one day, and I thought that I was like coming up with something original. And so I thought, you know, why are they giving IV fluids, the same IV fluids they give everyone else? If we're trying to hydrate the red blood cells, we should be giving something different. And I thought this something different was original. So I started looking around online. I said, has anyone written about it? And sure enough, she had written all this stuff about it. And I was like, this is my new hero. Well, we had the opportunity to work together with One Blood and for a blood drive. And I had a chance to speak with her.
Dr. Simone?
Yes. I'm
so sorry. There's several people that are saying, can you keep trying to put it on presentation mode, because they're having a hard time seeing it. Otherwise, you may be able to just zoom in a little bit using this.
Let me see. I'm going to try from current slide and see what happens. But for some reason, it's not. It never does that. I just did this with you, and it went to.
Yeah, we just walked through it. That's okay.
And it went
so
to
maybe using the slider down at the bottom right corner of your screen. If you can slide that over to the right a little bit, that's going to
make it a little bit bigger. Let's see.
Yes, please.
Okay.
Oh, the other direction.
The other direction?
There you go. Okay, folks, I know you'd like it to be in presentation mode, but this is what we've got. So if you'll just bear with us, we're going to make it as easy for you to see as possible in this mode. Okay, sorry about interrupting you, Dr.
No problem at all. I was just in the meantime seeing if I could get it to work again, like we did the last time so effortlessly. Okay, so I decided, you know what, actually, let me try one more thing. That might be too big. Is that too big? And let's see, hold
Nope,
on.
it's not, oh, just a little bit too big. There you go.
A little bit too big?
Nope, that should be okay as long as it's not cutting off any of your slides.
Okay, all right, let's see. Let's try to work with it. And so yes, so I asked her, I said, why don't people do this? Like, this makes sense to do, what I'm what I was thinking and what you've written about. And she said, well, actually it was given to the NHLBI, and there are other bodies like the American Academy of Family Practice and all these governing bodies that have written in support of these correct IV fluids, but for some reason it's not getting enforced when the doctor sees the patient in the emergency room. So since that's not happening, I decided that I should bring it to you so that you can then tell the doctor, as a patient, you can self-advocate for something so small, but that can make such a big difference in your care. All right, so when you go to the ER or the hospital and you look at your bag of fluids, you'll likely see something like this, right? So you examine the bag and you see 0.9 sodium chloride. It's also called normal saline. A typical bag of IV fluid has 0.9% sodium chloride. That's the same amount of salt per volume that the blood has. So they're called isotonic. It's just a fancy word for saying that they both have the same tonicity, or the salt. And so the net shift of water, nothing happens, right? Because there's enough salt over here and enough salt over here. I'll get into that more later, but it's the same amount of salt as the blood, and everybody in the hospital tends to get 0.9, right? That's kind of default. Okay. There's another one that's like the 0.9. It's called lactated ringers. It's the same amount of salt per volume also that blood has, but this one has some extra stuff in it. So it has something called lactate, so that people who in a sickle cell crisis, for example, when you don't breathe like deeply enough, or you're in stress and you're not getting deep breaths, you can get acidotic, and that lactate helps with that. And the electrolytes, the other electrolytes, they're called electrolytes, that lactate ringer has is potassium and calcium, right? So if you go in and you have an acidosis, lactated ringers will be used instead of the normal saline, but otherwise they tend to use, just the normal saline, so without any of these extra electrolytes. All right, so just showing you a bag of lactated ringers, and it pretty much has the same thing that normal saline has, except the electrolytes. Okay, so what are uses of normal saline? Well, if you're dehydrated, that's good. You give a little dehydrated, it will add some volume to your blood, right? And you can get dehydrated quickly. In the sun, if you're sweating, you're exercising and you're sweating. If you get sick, any of those times when you're sick, you tend not to drink as much, so you get dehydrated. Those are times when you can use normal saline if you're in a hospital. Okay, there's another type of IV fluid, and that's called half normal saline. So when you look at the bag, it will have 0.45 instead of 9, right? So that's half of 9 is 0.45, right? Or half of 0.9 is 0.45. And that is half the amount of salt per volume that the blood has, right? So where would you use half the amount of salt? Well, cardiac patients, for example, right? If you have a cardiac problem, they don't want too much stress on your heart. So they don't want you to have too much water, and water tends to follow salt. So they'll give you something with less salt in it so that you don't have any problems. The same as someone in dialysis, if their kidneys aren't functioning properly, they tend to measure the amount of salt those patients can have, because they don't want them to get filled with too much fluid and then have to dialyze that off. So 0.45 tends to be case specific. So which one is better, right? It depends, right? Nothing is ever clear cut, but which one would help me in a sickle cell crisis? Which one would help you in a sickle cell crisis? Okay. Okay. So in a sickle cell crisis, you can have water loss from inside the blood vessel. We call that intravascular. So, you know, like you bleed out, or, you know, or you have evaporation from sweating or something like that. That's water coming from the vessels. But you also get water loss in sickle cell crisis inside of the red blood cells, and that's intracellular blood, intracellular dehydration, right? So when we go to the emergency room in a sickle cell crisis, both of these are going on. There's volume lost inside of the blood vessels if we're sick and we're not drinking enough, and there can be volume lost in the red blood cells because they're sickling and they're not in their best shape. So it needs to get water too. It needs to be hydrated. We need to fix that, and we need to fix the water in the vessels. So I want you to think, I've already been saying it, but I want you to think water follows salt like boys follow girls. Now I know in this day and age, that's probably not the best example to use, but think about water just following salt wherever salt goes. Salt is like, you know, the chick. So salt doesn't have to do anything. It just have to be, right? And then water is like, oh, there's some salt over here. I need to go next to the salt. And so salt tends to remain in whatever environment it's in, and then water is the one that will shift to follow that salt. And I'm going to show you an example. So let's say you are looking at normal saline in the blood vessel, and then normal saline and how it would react with a red blood cell normally. This is the 0.9. Now 0.9, remember, has the same tonicity, has the same salt as blood, right? So when we take IV fluids and we give IV fluids in the vein, and it's going into the blood, and it passes by a red blood cell, can it get into the red blood cell and fix that dehydration that we just talked about? No, because the amount of salt in the cell is the same as the amount of salt in the blood. It's 0.92. So there's not going to be any net shift of water. There's going to be salt in the cell and salt in the blood, the same amount. And so there's no shifting happening. The water is staying wherever the salt is hanging out. Now, I decided to show you at the bottom how this looks. So S right here is for salt right underneath, right? So what we're looking at is salt in the blood, and then salt in the cell, right? So, or even if you were to put IV fluids in that blood, it's 0.9, so it's the same thing as blood. And then the salt in the cell would be the same, because salt in the cell is also 0.9. This shows what would happen if you were in a sickle cell crisis and the cell became dehydrated. So you have your 0.9 saline in the blood, and it's coming by, and it reaches the dehydrated cell. And I show that with the S's again and the W's for water. So S for salt, W for water. So the saline, it's coming, it's 0.9. It has the same amount of salt and the same amount of water. A dehydrated cell has the same amount of salt, because the salt, remember, it's not moving, it's just staying there. But the water left because it became dehydrated under stress, right? So it has less water than salt. And so it needs some more water in here. But because overall they both have the same amount of salt, it's not going to travel. It's not going to travel across the membrane into that cell. So what can happen is, to fix this, is you can give the patient half normal saline, right? So it has half as much salt in the water. So you give that, right? And I'm showing it to you down here. It has all this water, but it has half as much salt. And I put this W in black to show you that this is the free water, right? So all of the waters aren't taken. It's just half as much salt. In the cell, we still have this situation of dehydration where you have a whole lot of salt, but not as much water, right? So this is a perfect situation because this has too much salt and this has too much water. So what is it going to do? It's going to cross over. It's going to cross over the membrane and fill up that cell, and the cell will get nice and plump and round again and rehydrated because it was able to get the extra water from the 0.45, because the 0.45 only had half as much salt and it had more free water to be able to use to rehydrate that cell. So half normal saline, also known as 0.45% sodium chloride, that is the fluid of choice in a sickle cell crisis. And I hope that you can see by the diagram, by the schematic, that how that makes sense, how the free water is available to the cell more so than the 0.9 that has the same amount of salt as blood, and all of the water is being used up with the salt there. So if you're euvolemic, meaning that you're not dehydrated, that's just a big fancy word for saying you're not dehydrated, you can ask for half normal saline. Now, if you're dehydrated, can you get it? Yes, you can. It's just that at this point, either one can work if you're dehydrated. But most times we're not so dehydrated, like where we've lost a whole lot of fluid and they need to, rehydrate us, like, with a lot of, back to what our normal was. It's usually that we're dehydrated because we're in a crisis, and that is where you're going to have our red blood cells needing the extra water. And so giving 0.45 is going to much better address that, be much more likely to address that problem than the 0.9. The 0.9 is just going to hang out and watch the cell be dehydrated and go, can't do anything about it. I have enough salt over here and water's got to stick with my salt, right? So in a sickle cell crisis, 0.45 is the one of choice. And that's why I say you don't even have to worry about if you're euvolemic or dehydrated. You just go in and ask for it. And it's their job to then go check your blood and see, okay, is this patient like super dehydrated to where, they can't have half normal saline? And if they come back and say, you know what, we checked and we saw that, your sodium is very low, and so we can't give you half normal saline because that has low sodium too, so we have to give you normal saline. Then you reluctantly say, okay, I'll take a bag of the normal saline, But right after that, I need to go back to the 0.45 because I need my red blood cells rehydrated. Otherwise, I'm still in a sickle cell crisis, y'all. I'm still in a sickle cell crisis if my red blood cells are still dehydrated and nothing is being done to fix it. I'm going to talk a little bit about hypostenuria. I left it in. I usually talk more about this in the class, but when we have a crisis, we sickle in our kidneys and it damages something called the tubules in the kidneys that concentrate the urine. And this is referred to as hypostenuria. I put it there because you're going to hear this term, especially in sickle cell trait. For some reason, it tends to happen a little more. So, but it's not always that this is happening when you have a sickle cell crisis. It's just that when you do have this is what will happen. The tubules will break down because they got ischemic, because they didn't get the right amount of blood in time and oxygen right to the tissues. And so when it's damaged, it can't function right. So then it can't concentrate the urine. And so the net result is that salt will accumulate in our body. Okay, so the effect of too much versus too little IV fluid. Okay, so a lot of people, when they go to the emergency room or in the hospital, they think that they need to be on IV fluids all the time. And the truth is, if you are on 0.9, you're getting a little bit of help, because like as far as maybe some overall dehydration, but you're not getting help for your sickle cell crisis, because that needs to be half normal saline. So you can be getting all the normal saline in the world, it is not helping to bring you out of a crisis. And it can also, even the right bag, or even a half normal saline, if you take too much of that, that can also give you a problem. So for example, I'm gonna advance. So in the right amounts, right, it will dilute your blood. So if you come in and you're dehydrated and your blood starts to get a little thick because it's missing water and it still has all the cells clumping together, then it can dilute out your blood and reduce the sickling that way, right? This is the half normal saline that I'm talking about. And it will rehydrate your red blood cells and it will restore your fluid volume because you're getting fluids, right? But if you give it too much, then you can make hemoglobin levels appear lower in the blood. For example, this is the case with 0.9 or a half normal saline for the hemoglobin. When you give more water, think about having a certain amount of sugar and you keep pouring more and more water, it's getting more and more dilute, right? So if someone was to come and like drink some of that, they'd be like, oh, I can't even taste the sugar, right? Well, if someone were to pour a whole bunch, a whole lot of fluid in your vessels, they could hardly find the cells, the red blood cells, when they're measuring it in the lab. So it makes it seem like your hemoglobin dropped. But in fact, it's just because your volume expanded. That's the term that they use, is that your volume expanded with extra fluid. And so you have all your cells swimming around in there. And if they take a sample, that sample is going to look dilute and it's going to look like you don't have enough hemoglobin, which is why I tell people, if they come in and say that you need blood and you've been on IV fluid for sometimes they have you on it for days, ask them to stop the IV fluids and let you stay for like a couple hours and see if it normalizes or if it comes back up. Because a lot of times, once you start like peeing off the excess fluid, your hemoglobin looks normal again. And because it was never off to begin with, it was just artificially low because of all the volume that was in your body, right? If you are on half normal saline, it can change your salt balance, because remember, the blood is mostly 0.9 and now you're putting in 0.45. So you don't want to keep putting in 0.45 forever, because now you're going to mess up the, you know, the blood system. So you want to go in and get like a bolus of the 0.45 so that it can get into your red blood cells, and then you stop. Like, you don't need to be on continuous fluids. You just need enough to be able to get into your red blood cells, and that's it. And of course, if you have too many or too much fluid, you're going to have frequent bathroom trips as well. Okay, so symptoms of using the wrong fluid is pulmonary congestion. So you can get wet lungs, right? Where the water, there's so much water that it's starting to seep into the tissues, and that happens in the lungs, and you can start to wheeze. You can also, and when I say the wrong fluids, I'm talking about the 0.9, because the 0.45 is actually better for us in the sickle cell crisis, and hopefully we've established that. But if you have 0.9, it's not helping in rehydrating your red blood cells, and it's seeping into the tissues, not really doing anything, and it starts to cause pulmonary edema, which is wet lungs, and it can actually lead to acute chest. And so that's what Dr. Iffy and others have written about, is that it actually can put us at risk for acute chest. It can cause leg swelling. I'm sure you've been on IV fluids and then looked at your body and you're like all swollen. You're like, what? It can happen. It can a third space into the tissue. It can go into in between the tissues and cause everything to swell. And it's not getting necessarily into those cells because it has the same salt as the cells. So it's actually going everywhere else. It prolongs a crisis because it is not able to get into the red blood cell. This is the 0.9 we're talking about. And it can actually cause the whole body to swell. I'm gonna go through some references with you, because when you go to the ER, a lot of times when we hear these things, you know, people will ask us, well, where's your reference? I want you to actually take a picture of these screens that I am pulling up, if you can, and then you don't have to get the link. You can look for the title, you can Google that and pull it up, and you can read for yourself. These are all related to why you should use 0.45. So it's in emergency treatment of acute pain episodes for sickle cell disease. This is the NHLBI files. There's one that says poor control with normal saline bolus in children with sickle cell acute vaso-occlusive, or poorer control. So the normal saline actually doesn't help them as well as the 0.5, and they go into that. There's one that says approach to vaso-occlusive crisis in adults with sickle cell disease, and it teaches you that 0.5 is the way, you know, to go. And so these are the ones that I send to people when they start arguing with. I don't argue with people, I just send them information, education. This one is the emergency management of sickle cell disease, again, episode 68. And on and on and on. We have many articles that deal with the fact that 0.45 is the better choice for a sickle cell crisis. Okay, and so hopefully I'm pausing because I want you to be able to take a picture of these references and look them up by the titles, instead of the link, because unless you want to type out the link, that's fine too. That's helpful, especially when you're, and if you can pull some of these out and even print them out and put them in a binder, right? And then when people are asking you or pushing against you, I just invited I live in Florida. I invited a doctor here who manages a huge sickle cell clinic in Tampa. And 2 days ago, Sunday, our class it was just a staff meeting with the advocates, but I invited her to speak because she practices like this. She trained at Emory. She worked at Grady, and she's like, everybody there uses half normal saline. I don't know what the problem is. I mean, and she's in her world, she's like, you're really finding people who don't use half normal saline? And I'm thinking, where have you been living? But because she trained in a place where everybody, that was the norm, like in her world, she's wondering, why aren't people following the guidelines? That's the guidelines. And she's amazing. So she is, I had her come, and I also brought in some of the healthcare providers on our board, because one of them, I've had the hardest time having him switch from normal to 0.45. And I had to send him all of these that I'm showing you in order for him to be convinced. And so when she came yesterday, he was like, okay, but he had started using it, but it's like, it's a shift for our doctors. They're not accustomed to this information for some reason, even though it's been out there for years. So we're going to have to help by getting the articles, putting it in a binder, highlighting the pertinent places and showing it to them. And then, as a patient, you have rights of your body. So you can ask, may I have 0.45 normal saline? That should be good enough. So thank you for listening, and I hope you learned something. And if you have any questions at this time, I'm more than happy to answer them. And again, apologies for it not going into I'm not sure what this is. Okay.
Well, this was wonderful, Dr. Simone. So there was so much information here, and some of that, it was super sciencey. If you're anything like me, one of the things that helps is being able to watch it over and over again, because I'll get something new out of it every time. So just a reminder that we did record it, and it will be uploaded to our YouTube channel within 48 hours. So be sure to share it with your friends. You can share it on your social media. You can share it directly from YouTube. So we have lots of great questions. The one thing I do want to say, because you made a really good point, is that there are still providers, whether it's in the emergency room or whether it's after you've been admitted, who may not know this information. And we always encourage you to self-advocate for yourself, but we also want you to self-advocate in the most effective ways possible. So that means, blowing up or yelling or cursing them out is not going to be the most effective way to communicate something new. You want them to be able to hear what you're saying and absorb it. And oftentimes, if we become overly excited, and I'm not talking about just within normal, of being assertive, I'm talking about being more aggressive, they won't hear us. They just, they stop, their ears stop hearing. So it's important to be as effective as you can in your self-advocacy. It's also going to be important to have the conversation when you're not in an emergency situation. Have the conversation with your doctor and your medical team prior, maybe during a clinic visit, and asking them, are you aware of this? Do you know if the emergency room is aware of this? Make sure if you have a pain plan, is it in your pain plan in some way? Those are the ways that you can address these types of situations, even before kind of the heat is turned up around everybody, right? So I just wanted to add that. So we're going to ask some of these questions. We've got great questions. We've got about 9 of them. Let's see. How about for someone who has sickle cell beta plus thalassemia? Is there anything different about what you presented that would apply for those individuals?
No, it would be the same thing. So you're sickling, it's the sickling that's causing you to have an episode, and that sickling is what and this is a great person to read some of these references, because there is one that talks about cell deformity as it encounters normal saline and then half normal saline, just on the cellular level. And you realize that it's not so much the hemoglobin that is the problem. It's just the cell itself. It's a cell. It's still, at the end of the day, it's still a cell. A cell is a cell is a cell, but it needs to be, it functions to carry our hemoglobin. And when that hemoglobin gets dehydrated, it gets, deformed. And by the way, I don't know if people know this, but when your cell sickles, it can go in and out of that sickled shape until it doesn't change anymore. So it can go, from a normal cell to sickled, and then it's in a better environment, it goes back to normal, and then, but eventually, going back and forth, it starts not going back to normal, right? So what we're trying to do is actually get it while it's still reversible. And that's why I'm such a big proponent of intervening early, because, at that point, things can still reverse. You give, good hydration, you give, pain management, things can still reverse. So yeah. There's no difference. Oh, I can't hear you suddenly.
That's what happens when you're on mute. We have about 9 more questions, so we're going to answer these questions fairly quickly. Yes. We are so glad that our SickleSMART show reaches not just patients and caregivers, but also providers. So we have providers who are also asking questions. Okay. One provider, Dr. Chawla, thank you for coming. Thanks, Dr. Simone. This is a great talk and great information. However, she's asking, is it safe to give, I always call it D5.5, but 0.45 saline, a hypotonic solution to a pediatric patient quickly? I've heard of kids having seizures with the low salt fluid being given quickly.
Yes, okay. And so this is going, and she's right. This is why when I say too much of a good thing is not good, that's why I put that in there, because it can lower your body salt if your blood is 0.9 and you keep putting in 0.45. After a while, you can dilute the whole system, right? So that's why I put those slides in to say you can't keep doing that. You just want to give a little and then enough and stop. And of course, with kids, you want to calculate their fluid. Actually, one of the references I put there is a fluid calculator, so that you put in, and if I'm talking to a provider, then I know that she'll understand like maintenance and half maintenance, right? So you can go up to half maintenance and stop. And so that you're not, converting, you're not causing the whole system to have a fluid shift, and you can, and then you don't have to keep doing that. And if it's someone that's drinking and tolerating POs and such and eating, their salt intake is going to offset that very quickly. But that's what I would say.
Okay, that's excellent, because we want to make sure, even when, and let me put our disclaimer, we do not give medical advice, we give information. So it is important that you have the conversation with your medical team to determine what is right for you in
Yes.
those times. We do not make blanket medical statements. So it's important to understand when it applies to you and in which circumstances, and when it doesn't apply to you, and when it doesn't apply in certain circumstances. All right. Listen, sickle cell we know is complex. That's one of the reasons why we have some of the challenges that we do, and that there's not enough education, because there is so much, and there are different nuances or different things that people need to know for different situations. So it's not as straightforward as sometimes it can appear when we're doing education, but just know that the goal is to ensure that your medical team is aware of all of the studies and all of the research that is being done. And there's so much that they may not be able to stay on top of it all the time. So it's important to have that conversation. Okay, disclaimer over. Another question from Karen. She's a nurse practitioner, and would you be able to share literature to support the use of half saline? And I believe you did at the end. So she may have asked those questions before you put those slides up. Now we have a patient, and this is a very real situation, because she says that she's asked for 0.45 saline several times, and doctors refuse to give it to her. Now I'm going to reframe that question in a couple of ways, right? Because first and foremost, how do you know if you're dehydrated? Is that a standard lab test? Like, is that a standard order set at the beginning when you are in the hospital or at the emergency room or in an infusion center? Is that something that they are checking immediately?
Right. So what they would do is they would check an electrolyte panel. And if you remember at the beginning of the talk, I said, what I want you to do is give the doctor this information. And then if they come back and say, oh, your salt is too low, so we can't give you 0.45 or something like that, you at least know that they took the information and assessed your situation and then decided that it wasn't the best for you, right?
Yeah, it's about the why.
Right. So it can be that in her situation, that now if the doctor didn't even have any labs and just said no, then that's a whole other. But if they said, actually your sodium is low, kind of like what I was saying in the beginning, go back and watch this, because in the beginning I said, give the information to the doctor, and then if the doctor takes your blood and he can see or she can see that your sodium is low, then they'll make the decision of what to give you. And at that time, at least they're making it with information. You've given them the information, and then they've included it in their decision making, and then came up with the best thing for you, right?
Yes.
I'm not saying that you go in and you say half normal saline or bust, because if you are low sodium, then you don't want them to add half normal saline in that situation. You want them to get you, with the right amount of sodium in your blood,
Balance you out. Yeah.
and balance you out, right? And they can make that decision once you give them the information.
So I love that response, and really it reinforces the importance of having the conversation with your medical team prior. It's really, really hard to get them to change orders in the middle of a crisis, right? They are in crisis mindset, and and whatever they feel is best in that moment, and it's really hard to absorb new information in the moment. So it's the best way to address that, and I'm talking specifically to those who feel like your medical team or the physician is not listening to you. Make sure that you do your best to have had the conversation with members of your medical team prior to an urgent situation like this, or in a pain crisis. And then if that is not, if that's still not seeming to get anywhere, then have a conversation, maybe with the head of the sickle cell department or the head of hematology. There are ways to escalate your concerns, and there are effective ways to do that. And you can always reach out to either one of us, and we'll talk about how you can reach us shortly. Another question that we have is, so does hypoxia,
Very good.
I probably messed that up.
No, you got it. You got
Does
it.
that cause the color of the urine to be dark color? And is there a way to make the urine color lighter, in like a straw-like color, so a very pale yellow? Or does it mean that your kidneys are damaged and can't concentrate the urine enough? That's an interesting question.
No, hypoxia it doesn't have to do with the color of your urine. That usually tends to be related to the bilirubin in your that the body's trying to get rid of, and which is usually produced by liver and going through, filtering through your kidneys. So that's one, doesn't have to do with the other. It is considered cellular damage in the kidney when you do have breakdown in the kidney, and that's why over time, we have people see a nephrologist and make sure that their kidney function is okay in sickle cell disease, because they know that they can sickle in their kidneys and can have complications, down the line. There are certain labs that get tested often that check things like your glomerular filtration rate and your creatinine in the blood, and those things also give an indication of how well your kidneys are functioning. So if those are doing okay, then you might have taken a hit, but you're still doing okay. So there's a way to keep track of it.
I think that's a really important question, because oftentimes, and I know even for myself, when my son was younger, obviously he's 26 now, so I know so much more than I did when he was, say, 6, right? They do a whole panel of labs, and they just, I've seen it where they just say, okay, everything looks good. Well, tell me what that means. What labs did we do? What are we measuring? What's the baseline? What should it be? How will we know when we should be concerned? Like, we also have to get involved enough to be asking questions. And I get it. Sometimes you don't know what you don't know until after you should have known it. But it's because we had the reason that we do these education sessions is so that it can start getting your wheels turning and thinking. And so that, I always encourage people, when you go to the doctor, bring a notebook with you. Take notes, because you might not have the question then. You might have to go home and look some things up, and make sure you know your sources. Google is wonderful if you choose the right sources. There's also bad information, but you will know when it is an article, a scholarly article, when there are other physicians and other contributors to the article, so that it's not just an opinion piece. That's what we have to be everybody has an opinion. Everybody has unique experiences. We don't know all of the details behind their experiences. So it's really important to make sure you're using science-based factual information where there have been contributors to better understanding it. All right. Would it be important for someone with sickle cell disease to be aware of their baseline hemoglobin when we're talking about overhydration? Interesting question.
Okay. Well, it's always good to know your baseline hemoglobin, because if you're going into hemolysis, you could be, underproducing, but very likely if you're if your hemoglobin is normally, let's say, a 9, and it suddenly goes to an 8 or a 7, you start wondering, like, what's going on? Am I breaking down some, cells, or am I not producing enough? What, like, where is this coming from? So it's always good to know. And yes, when you go in, if you go in with a baseline hemoglobin of 7 and you didn't have any bleeding, you didn't have anything that would change the the level of your hemoglobin, except that you were in IV fluids, and then suddenly your hemoglobin is down, and the only thing you're doing is taking some labs in the morning, well, that shouldn't be enough to drop your hemoglobin. So it might be, I mean, it will drop it a little bit, but not by that much to where you suddenly need a blood transfusion. So it is good to know where you normally are, or where you came in at. Like, when you came in, what did they say you were? And then if they're saying, oh, now you need a blood transfusion, well, okay, hold a minute, let me ask, can you please, and very respectfully, can you please, take me off and let me, just be on just liquids that I can drink, right? So take me off and let me see if it normalizes, and if it actually comes back up, because then I might be volume expanded.
Yeah. And I'm glad that there's several good things that you said. Number one, I used to get frustrated because I was like, why do we need to keep doing labs? We're talking about all of these different reasons why they keep doing labs, why every day you might have labs in the morning, labs in the afternoon. They are monitoring some of these levels so that they can know what's going on. I think another thing about that question is, yes, it's valuable to know your baseline hemoglobin, so that if your hemoglobin drops substantially, it begs more questions, right? It's not because it's any one thing, it's because now they need to consider, okay, what is the source of the drop in the hemoglobin? Right. Are you hemolyzing? Are you hypervolemic, or, overhydration, right? But there's several different things that could be going on. And so again, we don't want to overgeneralize, but we want you to be aware so that you can ask the questions. I love what you said, Dr. Simone, about, pausing before you get that blood transfusion. Outside of urgent situations, like, we're not talking about urgent situations where we know we got to get you some blood very quickly. We still know that that there are some cases where we are over transfusing, and that can be dangerous. Also, with the blood supply shortage, it's wasteful. And so we want to make sure that we keep blood, especially for those of us of diverse ethnic backgrounds, where blood is it's not in abundance for anybody, let's be real, but it's even more scarce for people of color. By the way, donate blood, because we need it, especially if you're a person of color. Ray's shameless, I'm going to plug it.
No, go ahead, girl.
But it is important to not over rely on transfusions just because your hemoglobin goes down. There's a lot of different things that can be going on, and it might not be that you just need blood on top of blood. Okay, so I'm going to leave it at that. Another question. Your information regarding kidney damage due to sickle cell and the wrong saline is very valuable. I'll have to check from now on what I'm being given. Also, how can we protect our kidneys from daily damage?
Wow, that's a good question, and I don't know is the answer. If I knew, I mean, of course, hydrating is always great. Yeah, that's where I would start, is hydrating. But I don't think there's any one thing that I could say that this will definitely preserve your kidneys. So outside of, eating well, making sure that we're not taking too many medications that can tax the kidneys. Some medications are broken down through the kidneys and some through the liver. It's usually either the liver or the kidney, and some stool, but like the liver and the kidney. And so if something is something like ibuprofen is heavy on the kidney, something like acetaminophen will be heavy on the liver. So you want to make sure that you're not taking things that are too taxing on your kidneys. If at least you can look those up, that would be helpful.
I love that. If you're a person living with sickle cell disease, yes, hydrate, hydrate, hydrate. If you are a caregiver of a child with sickle cell disease, look, when I was in the clinic, here's what I would tell kids. How do I know, if I'm drinking enough water and when do I need to drink it? But I would tell them, think about your body in the same way. And I would ask them, have you ever had to flush the toilet more than once so that everything would go down? And they would typically look strange at me and then be like, yeah. Well, that's why you need to drink lots and lots of water, because you're flushing your system. And sometimes you need that extra flush to make sure everything's moving through, because those blood vessels, they get sludgy and all of that good stuff, right? You have to be creative with your kids so that they understand, because they are old enough to understand the whys, as long as you explain the why in an age appropriate way, something that they can attach their thought processes to. It's important that we don't keep all of that information to ourselves as caregivers. We have to make sure that we're explaining it well to our kids. Pediatricians typically do that well. Do I think they could do it better? Absolutely. I think that there's always room to better explain, but we also have to ask the whys. Ask why and have your notebook and say, I may not understand it right now, but I'm going to go read more about this. But ask why. It makes the difference. And then the other thing that you said, and again, it's a shameless plug. Everything doesn't work for everybody. That's another disclaimer, okay? Everything doesn't work for everybody. However, for those who are on hydroxyurea, one of the benefits of taking hydroxyurea is that it protects the organs. That is part of the reason that they attribute a longer life. For those who take hydroxyurea. I know it's not for everybody, but for some, it really is a game changer. And so that is another positive reason to take hydroxyurea, or another benefit to consider if you are on the fence about taking it. All right, now, I know that everybody wants the slides. People are asking that the slides are proprietary. They are proprietary, and so they will not be shared, but the video itself is shared. And then I do want to get this last comment that someone said, because I do think it's important. A bit worried about you saying try to avoid transfusions if your blood level is low. It's just that I know sickle cell patients who are on regular automated red cell exchanges. Without these regular blood exchanges, these people would not be able to function well and may spend more time in hospital. I do worry that regular transfusions may cause blood antibody buildup. So you just repeated exactly what I said when I said it. I said for those who have need of it, that there is clear medical reasons that they need blood. So whether that you're on a transfusion program, whether you have acute chest and it's a medical intervention, whether they have done the labs and they discover that you are hemolyzing so quickly and your retic count is not complementing that, there are good reasons clearly that you should be getting transfusions. What I want to do is, when you're in a pain crisis, there are a good number of people that feel like they can just get a blood transfusion to help the pain, and that's not always the case, right? That's when I want you to just pause and ask some of these other questions. And again, it's better to have these questions when you're in a clinical setting, when you're meeting with your doctor or your healthcare team, than in an emergency room setting. Those individuals are typically not sickle cell experts, though they may be experts in medical care as a whole. They may not know all of the inner intricacies of sickle cell, when to and when not to. And I would strongly recommend, if your medical team or if your ED team is not aware of ASH's guidelines for caring for individuals with sickle cell disease, give them the link. They also have pocket guides. ASH has pocket guides of their care recommendations. Order a few so that you can give them out to your medical team or the emergency room, or when you go to the hospital, that you have it handy right there. Sometimes it's easier to hand them something that comes from a body, an education body that is highly respected, highly regarded. And in that moment, they can look at it a little bit differently. But there's again, just making sure that they have the knowledge that they need to make the right decision for you at that time. Okay.
Let me say something too, real quick, because sometimes when you say something, and this happens to the best of us, you might make the disclaimer, but someone's ear is just bent on one piece of that information and they run off with it, right? And then everything is built around, a story is built around, the part that gets extracted. If a person comes into the emergency room and they're at and they're being told they need a blood transfusion, I'm not asking you to stop and wait to, see, because you weren't getting fluids at that point. You just came into the emergency room from home, very likely. I'm talking about if you're in the hospital, there's nothing else. Like I said, you're not bleeding out or anything like that. You're simply getting blood work for your sickle cell crisis. And then you notice that your hemoglobin drops. It's good to know the baseline so that you can then go, okay, maybe I'm volume expanded. So if they ask me for, we think you need, and this happens all the time, I promise you, I will call and people will say, well, her blood dropped, so she's going to need a transfusion. And I say, okay, can you just take them off just for a couple hours off of the IV fluids? And it's either that they don't need it or they need less blood than we thought, because they were volume expanded and it reflected an erroneous result because of that. So that's all I'm talking about, is when you're already in there, you're not coming in an emergency, you're not bleeding out that we know of, you're just there for a sickle cell crisis and whatever else is, maybe going on, no blood loss or anything that we know of, and then it suddenly goes down and they ask you to have a blood transfusion. 2 hours, it probably takes 2 hours for them to type and cross and screen the blood. So asking them to take you off of the IV fluids during that time is very reasonable. And then just asking them to test it before they transfuse you, if they went ahead to type and screen you, just right before you do a stat CBC, because oftentimes you need less blood than they thought. And that's happened a lot of times too, because your volume expanded.
Well, I think this is wonderful. And I also, you know what else I think is wonderful? I think that the Sickle Cell Medical Advocacy Program that you have is wonderful. Will you tell us a little bit about the Sickle Cell Medical Advocacy organization that you recently started?
Yes. So I, out of a lot of pain comes beautiful things, right? So I saw a lot of things happen in 2020. Whoa, sometimes I lost a lot of people in 2020 and I thought something had to be done. And so in 2021, I started this program where I teach regular people in the community some very important pieces of information that helps to advocate for the patient in the emergency room and in the hospital through their hospital and discharge. And I teach that. I created a course, and now it used to be 12 weeks in the beta test. Now it's 9, because people gave me feedback. It's too long, but and they were right. so now it's 9, and it's had some amazing feedback. In fact, I'm putting together some of the responses that people have after the class, and it touches my heart so much, because people's lives are changed. And for the people who use the information, even for themselves, to self-advocate, the one requirement I have is that when you come in, please don't just take this for yourself and leave. A part of what I'm trying to do now, at least now, there will be a time when you can come in and just take it for yourself. But for now, I'm trying to teach people who will pay it forward, who will help someone in the community when they're going into the hospital. So not that you can't help yourself. I actually do pair people up. If they're an advocate, they're automatically getting help if they need it, right? So because we take care of our own. But if someone comes and says, I am in this dire situation and I need somebody to please help me, I don't, I'm sick, I don't know what to say to get what the right answers are to take care of myself. I just need some feedback. And so there will be someone there to pair with that patient virtually and to be able to give the information, whether it's from the NIH guidelines, the ASH guidelines, the ACEP guidelines for American College of Emergency Physicians. They actually adopted a lot of the ASH guidelines. And so it's kind of funny because the emergency room doctors don't know the emergency room guidelines that were made for sickle cell. So it's good to be able to give people that and say, hey, you know, and it is difficult, like Ray said, to teach in the moment, but they stop long enough when you give them, like, you know, little tidbits, like, you know, it's like a heart attack, you know, just like a blockage causes tissue damage, our blockage causes tissue damage. Don't keep her sitting there. They get that and they'll change, right? So little things like that will help them to change. And so that's what I'm trying to do. So far, it's just been an amazing experience.
This was wonderful. I think that this is going to help a lot of people. Again, the information that we present is not to be generalized, but you know, we are our own encyclopedias. We should be keepers of knowledge. We might not know a lot about a lot of things, but we could know a little bit about a lot. And at least it gets the conversation going. It expands the conversation, and it shows that you're involved with your care, that
Yes.
you care about you. Too many doctors have this generalized feeling that we don't care enough. I don't agree with that, and how they come to that conclusion. However, one way to show them is asking these questions, asking the why, having your notebook. And so without further ado, I do want to make sure that I am saying thank you to our guest. And my slides actually finally came up. And let's see. Okay, I got mine into presentation mode. So again, as I said, it's not now available. That's my slide that I'll be using tomorrow, y'all. I didn't make two separate slides, but it will be available in 24 to 48 hours on our YouTube channel. You can use our quick links. As you see, we have a link tree, but we also have a quick links for our YouTube channel. If you look on the left of your screen, bit.ly, SickleCellMN -YouTube as well. And then if you haven't already, to subscribe to our Eventbrite channel. That way you will get a notification whenever we post new events that you can register for. And don't forget to subscribe to our YouTube channel as well. Dr. Simone talked about sickle cell medical advocacy and her organization, and you can find her at sicklecellmedicaladvocacy.org. And her email is on the screen as well. You can also follow Dr. Simone on many of the social media channels. So we invite you to do that. You all, we bring on guests that are meaningful to the community, and that really can share their knowledge and their experience, their expertise. And Dr. Simone, you are absolutely one of those individuals. So we thank you.
Thank you so much. I appreciate that coming from you. It means a lot.
Thanks. As y'all already know, I am always going to be that voice. First of all, I started some of my medical experiences in the blood banking industry. So it's near and dear to my heart for a lot of reasons. I spent almost 10 years in transfusion medicine and blood banking. So donate blood, it saves lives. Yes, our blood saves our lives. We need to make sure that we have enough diverse blood. It's not that blood has a color, but ethnicity shows up in very unique ways. And I used to call them the wingdings with kids. Now they don't even use the word wingdings. That's how long I've been in doing this. But it is important that we have lots of different types of blood to meet lots of different needs in lots of different people. So we want you to donate blood. And then if you want to learn more about why we need to diversify the blood donor pool, last year we did a presentation with Dr. David Mayer from the American Red Cross. That is on our YouTube channel as well, and you can check it out. Our next Our next SickleSMART episode that we have coming up is super exciting. It's pharmacology. That's a big word that we never really think about, but it's how a good pharmacist can save your life. Do you know that it's important to have to get to know your pharmacist? That if you can get a pharmacist on your medical team, there is great value in that. And Dr. Lemitra Scott, who is also a warrior mom, as well as a pharmacist, is going to come and talk to us all about it. I love what she has to say and how she helps us to understand why we need to better understand the pharmacology field. Then our upcoming activities, we had our first Cooking for Your Health Sickle Smile Wellness activity. It is a monthly virtual cooking class with live cooking demonstrations. Listen, we don't talk about nutrition. What we put in our body is either going to help us or hurt us. And so being able to cook with non-inflammatory ingredients can be fun. It doesn't have to be boring. We don't have to feel like we're chewing on cardboard. And food is my friend. So I need to know different things that I can cook and how I can cook it to be healthier. Our walk and talk, although it was canceled on June 25th because of weather here in Minnesota, our next one is on Saturday, July 30th, and then save the date for our sickle cell walk. And last but not least, and this is very important because I want people to understand the importance of your voice. Your voice does matter. We need you to tell your stories. We want you to share your medical experiences, both good and bad. Why share your good experiences? Because someone who had a bad experience is looking for where to go. So we need to know, where did you have a good experience? Is this a common? Do you have just this awesome relationship with your medical team? Do they listen to you? We want to know that so that we can elevate them in the community and let them know that we appreciate them. But your voice does make a difference. You can report, you can tell your story, report your medical experiences. This is not just for Minnesota, but it is a form that you fill out. And again, we love Bitleys. Our voice matters too. All right. And so we invite you to share your story and tell us about your experiences. Let me move that. Okay, well, we thank you all for coming. Oh, one last person I want to say thank you to. I'm so glad I didn't forget. I want to say thank you to our, we have an assistant this summer, Kiana Davis, and she is our intern that's working with us. And I'm so grateful for her. So y'all was probably like, who in the world is this Kiana girl that's doing all this typing? And you know, she's hyping Ray up. Okay, she's our intern and we so appreciate her. So just shout her out, tell her thank you. I appreciate that. And thank you to patients, thank you caregivers, thank you providers, thank you community members. Thank you for showing up and caring enough to expand your understanding and to make sure that you are utilizing your skills in the best way with the sickle cell community. We love you. We appreciate you for that. All right. Have a good night. I'm going to stop recording. Dr. Simone, if you wouldn't mind staying online just a moment. We'll see you next time, folks.